Alrighty, week 4, antimicrobials and cancer immune system stuff. Alright, so systemic mycoses are simply systemic fungal infections. Treatment can be very difficult to manage with these because the infections are often very resistant to treatment and they may require a prolonged therapy period. Broaden that, there we go. No, come on, be nice. Oh, come on, where was I? Blah, 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 there we go. So with systemic mycoses, we can have either opportunistic mycoses, or we can have, no, stop with that. What are you doing? We can have opportunistic mycoses for those who are immunocompromised, and common agents or etiologies would be candidiasis or aspergillosis. And then we have non-opportunistic infections, which can infect any host regardless of their immune system status, such as blastomycoses. Blastomycoses are oftentimes found in soil from decaying wood. They can enter through the lungs and infect the lungs, the bones, joints, skin, or other areas. Amphotericin B is our main medication that we're going to use for very severe, significant, potentially life-threatening fungal infections. It's a pauline antifungal, broad-spectrum antifungal. It's only given via IV, and it's mostly only ever given for a systemic mycosis that is definitely progressive, potentially fatal, because of just how severe it is. So when it comes to mechanism of action, most of the time it is fungicidal. How it works is it binds to ergosterol, with ergosterol being a part of the sterol family, and so it resembles very much cholesterol. And remember, cholesterol is the lipid that is used as the foundation for the bilipid membrane, the cell membrane around every cell we have in our bodies, and that most what are they called? Eukaryote cells are going to have these bilipid membranes. I think it's eukaryote, not prokaryote. Yeah, I think I have those right. It's been a while since I've done Bio 102. Ergosterol and cholesterol are very similar. Amphotericin B has a much stronger affinity for ergosterol compared to cholesterol, which is good because that way we can have most of the effects limited to the fungi rather than our own host cells. But that doesn't mean that we're not going to have some carryover as well to our own cells. When it does bind to ergosterol, what it's going to do is it's going to start to disintegrate some of those ergosterols, leading to an increase in permeability in the fungi cells. That's going to lead then to the cell leaking intracellular cations like potassium, magnesium, but it will also bind to some cholesterol cells as well. When that does happen, we're going to have some infusion reactions. There will be some form of infusion reaction in all patients. It just varies depending on how susceptible they are and how big a dose we're giving. Some of the things we're going to have are rigors, which really are fever and chills. It's a sudden chills and shivering as at the onset of high fever. We can have tachycardia, hypotension. A lot of this comes from a release of pro-inflammatory cytokines. These reactions will last for about 1 to 3 hours after the infusion starts, or they'll come on around an hour after they start and last for 1 to 3 hours in total. We can try to reduce the number or severity of symptoms by giving the medication in a lipid base and slowing the infusion rate. Ampho-B is available in 4 different types of preparations, with 1 of them being the conventional formula and 3 of them being lipid-based formulas. The problem is that the lipid-based formulations are much more expensive, so not all hospitals are inclined to utilize the much more expensive lipid base unless it's really required. Some of the other adverse effects are going to be nephrotoxicity, which is going to occur to some degree in all patients. It just may not be very much. If we're looking at something with 4 grams or more then we may actually have residual permanent impairment. Um, if it's below 4 grams in total that we're giving our patient, we're going to still see some level of nephrotoxicity, but it'll be reversible, may not be as significant. So if we can, we try to keep it at under 4 grams. We can also see hypokalemia due to damage to the kidneys. So if we are having, kidneys will reabsorb potassium. And so if we have damage to those tubules that are meant to reabsorb potassium, then we're going to have more of the potassium excreted out in urine. We can also have some bone marrow suppression, which can lead to pancytopenia. So our nursing implications are going to include pre-treating to try to reduce the infusion reactions. We're going to try to pre-treat with diphenhydramine and acetaminophen, so Benadryl and Tylenol. And then meperidine is an opioid that we can try to give to reduce and treat the rigors. We also want to give it as a slow infusion rate. We also always want to give 1 liter of normal saline to try to promote adequate renal perfusion, which will help to reduce the impact, the nephrotoxicity that we can get with amphotericin B. We also want to avoid NSAIDs because NSAIDs can promote renal or can decrease renal perfusion, making it so that we have increased renal damage. And then any other nephrotoxins we want to just try to get rid of. The 1 liter normal saline, we may give this right beforehand, or we may give it during just to ensure that we have adequate blood flow to the kidneys. That really comes down to the local policies. We also want to check the serum creatinine every 3 to 4 days. And I actually have something over here that goes a bit more into creatinine. Before I get to that, phlebitis is also very, very common. And so we want to make sure that we change the IV site frequently or implant a central line to ensure that there's as little inflammation as possible. So regarding creatinine, knowing that you guys are getting into acute and looking at more of the lab results and whatnot, so a clearance test is going to be somewhat what this is referring to. So this is going to be a 24-hour collection of urine. And so oftentimes we'll have maybe say a catheter, or we'll have a top hat put into the toilet of a patient's bed and tell them we need you to urinate into this all the time and let us know so that you don't flush any of it away and we can collect all of it within this next 24 hours. And this is going to be used to determine the renal function of our patients. What it assesses is the quality of glomerular filtration and the quality of tubular reabsorption. So glomerular filtration, how much filtrate are we putting through the filters in our kidneys? Quality of tubular reabsorption, how well is the tubules inside the kidneys reabsorbing the things that it's meant to reabsorb? Quality of renal excretion, how well is the kidney excreting the things into urine that we're supposed to be excreting? So the clearance test itself measures many different substances. The most important one, or the most useful one that we can use, is the creatinine clearance. So creatinine, which is different than creatine, is a waste product of skeletal muscle. Creatinine is the breakdown of creatine, which is an energy product used in skeletal muscle. It is almost entirely excreted in the urine. So we should see pretty much very minimal amounts in a blood sample. We should see more of it in a urine sample. And creatinine clearance is the best measurement we have of renal function. And as renal function declines, we're going to have a decrease in creatinine clearance. Because in order for the kidneys to function well, to allow the creatinine to go through the glomerular filter and to be adequately ran down the tubules and out the collecting duct, we have to have adequately working kidneys. If they don't work, the creatine is then going to build up in the blood instead, and we're not going to have as much let out through urine. I'm actually going to make this bigger in case people can't see it as well. So all of that stuff, in case you guys want to write that down, I don't know. All of that, blah, blah, blah. So that's creatinine, and that's something we're going to check with a creatinine clearance, or in general, a clearance test. Blood urea nitrogen is going to be from, as the name implies, a blood sample. And this is also going to be used to assess renal function and kind of checks creatinine in a different way as well. Urea nitrogen is the end waste product of protein metabolism. So when we have high levels of BUN, that can indicate decreased renal excretion, hypovolemia, muscle wasting from starvation, someone who takes a very high protein diet, use of nephrotoxic agents. So there are a number of, say, antibiotics that we use, or that we learned about last term, that have nephrotoxicity as a potential side effect. This is going to be one of the ways in which you can determine, does it or has it made an impact on the quality of the kidneys, on the renal function. And there are a number of other indications that high levels of BUN can make. Where is my pen? I'm like, you go away. Go. For low levels of BUN, that can indicate inadequate dietary protein, so the opposite here of very high protein diet. Malabsorption syndromes, so we're simply not absorbing the protein in the first place from the GI tract to allow for it to be broken down, metabolized, and excreted. It's just simply going through into feces. Or severe liver disease, and BUN is synthesized in the liver, so if the liver has damage, that's going to result in decreased levels of BUN. There are also other levels or other reasons for why we would have low levels of BUN. Now, what we're going to look at realistically in the hospital setting, we're going to see creatinine clearance as potential, but that's more of a specific order, whereas BUN and creatinine in serum levels, not in urine levels, are going to be routinely taken as part of, I think it's a metabolic, basic metabolic panel. I can't remember which order it actually is. But regardless, you're going to see these on virtually all patients. And so it's going to be a much easier route for us to be able to use to identify how their renal function is doing. So we're going to see measurements taken from the blood, not urine. And the normal ranges that we're going to have are really going to be based off of whatever each individual facility, because each facility is going to have different equipment that measures BUN creatinine at different levels. A common range that I've seen is going to be 15:1 to 24:1, which means for, say, every 15 milligrams per deciliter of BUN, blood urea nitrogen, there should be roughly 0.6 to 1 milligrams per deciliter of creatinine. So 15:1, 15 milligrams to roughly 1, depending on the ratio we're talking about, of BUN to creatinine. A high ratio, so if that looked like 30 BUNs per 1 creatinine, then that would be the same indications as having high levels of BUN. If we have a low ratio, such as 10:1, we would have the same indications as low levels of BUN. So it's a little helpful tidbit for you guys there, because I know that that's kind of confusing to some people. Okay, so back on track. So now we have our fluconazole, which is our azole antifungal medication. It's a broad spectrum. We can be given both IV and PO. We're going to be giving it IV for systemic mycoses and PO for a local infection. So like, let's say someone has candidiasis in the vagina, a fungal infection. We could give fluconazole as a medication to treat that in that case. We can also have it as an alternative to Ampho-B for most systemic mycoses, but that's given that perhaps a patient is going to be really predisposed to more significant, more severe reactions from Ampho-B compared to your normal patient, or perhaps the systemic mycoses that that person has that we want to give fluconazole to doesn't have as progressive or life-threatening of a systemic mycoses that our patient who we want to give Ampho-B to has. So Ampho-B is fungicidal or fungicidal, whereas this is fungostatic. So ampho-B kills directly the fungal cells. Fluconazole only inhibits their growth and replication or reproduction. So this, instead of binding to and kind of destroying ergosterol, this fluconazole will inhibit the synthesis of new ergosterol. So it kind of keeps fungi right where they are rather than progressing on. Doesn't make it less effective, it's just sort of a different way of doing it. But from what I understand and my limited amounts of knowledge from this, ampho-B is considered to be a little bit more effective for and quick acting compared to fluconazole for severe systemic mycoses. All right, so for adverse effects for fluconazole, they have lower levels of toxicity than ampho, which is great. Basic side effects here. Unfortunately, we have a different drug-to-drug interaction compared to ampho-B. So fluconazole has the inhibition of drug metabolizing enzymes. So that can inhibit or that can raise the levels of many other drugs, and we need to be careful about monitoring the drug levels of other medications. Maybe consider lowering their normal dose so that they run less of a risk of entering a toxic level of drug levels while they're on fluconazole. All right, anti-tuberculars. So tuberculosis is a global epidemic, kills a lot of people. U.S. cases are really declining a lot, which is great, and 95% of the cases are occurring right now in developing countries, and this is due to AIDS and HIV, which are actually considered kind of a comorbid factor for each one, and the increase in multi-drug resistance because of a lack of access to quality, consistent treatment for tuberculosis. So when it comes to therapy, there are several issues with therapy. The tuberculosis in general is slow growing and it requires prolonged therapy to really properly treat. There's also the potential for drug toxicity in treating tuberculosis because we're talking about giving multiple different drugs here at once. We also have a very high risk of poor patient adherence because of how long we have to have them remain on anti-tuberculars, how inconvenient it is, maybe a lack of access to the cost to treat them, or access to using a vehicle to get to the location for treatment. There are numerous barriers to patient adherence. And every time a patient does not continue properly with adherence, that promotes drug resistance because every time we have exposure to antibiotics without destroying the bacteria that we're trying to destroy, we are encouraging resistance. So treatment overview, normally they don't need to be hospitalized. They're not normally that severe at this point. Normally we catch it a lot earlier because we've improved our screening abilities. We will always be treating with greater than or equal to 2 drugs. Actually, I think most of the time we do it with 4 drugs, sometimes even more than that. It is standard now to have direct observed therapy, which is critical for patients, that we are actually watching them, if not directly administering the medications themselves, so that we can ensure they are actually taking it on time every single dose, which is really inconvenient for patients, but it's a massive public health initiative. The therapy is considered effective once there are no longer any microbacteria that grow in sputum and no colonies in the cultures that we grow. So drug resistance can occur either as an inherent source, where the person gets infected by an already resistant strain, or we can develop resistance through having a repeated ineffectual course of therapy. So another public health reason for why we really encourage having direct observational therapy is that as these people break away from therapy, they don't continue for any number of reasons, we are now promoting drug-resistant TB, which is even more significant of a health risk for everyone else. So when it comes to drug resistance, TB can be either classified as multi-drug resistant TB, MDR-TB, which is resistant to both isoniazid and rifampin, or we can have extensively drug-resistant TB, XDR-TB, which is resistant to still isoniazid, rifampin, but also fluoroquinolone antibiotics and at least one injectable second-line antibiotic. When it comes to treatment, we really want to find out what drugs, which of our options that we have available, is this TB sensitive to. So we're always going to start with having a drug sensitivity culture. So we're going to grow a culture of the mycobacteria that's in this individual and then test it to determine which drug it's sensitive to. The therapy is going to begin immediately after we've already started the lab, because the lab itself is going to take 6 to 16 weeks to conclusively come back. So we don't want this person going out, I mean, that's a long time, so we don't want this person going out spreading the disease more. We don't want them to continue to progress and become worse off. So we're going to start with whatever happens to meet like the empirical evidence, I guess you can say, of what the local TB strains have been. So we're going to go with whatever kind of the other people who have had TB in that area have successfully worked with. And we're also going to base what we start this person on based on their immune system, their immunocompetence. That's a difficult word to say for me. Go away. So we're going to start based off their immunocompetence and based off of what the local data or the data about local strains indicates. And when we do start them, there's going to be then 2 phases to their treatment. There's going to be the induction phase and the continuation phase. The induction phase, so let's say we're going to talk about a drug-sensitive form of TB. This is going to then last 2 months. And the purpose here is to eliminate actively dividing tubercle bacilli. I think I'm saying that right. The continuation phase then will be the 4 months after that, given it's drug-sensitive TB, where we try to eliminate the intracellular persisters, so the ones that didn't happen to get wiped out well from just the induction phase. When it comes to drug-sensitive TBs, therapy is usually initiated with a 4-drug regimen, normally always with isoniazid and rifampin being included. With a drug-resistant TB, more drugs are added. Sometimes we can go up to as high as 7 actual drugs or antibiotics being used to try to treat tuberculosis in a drug-resistant form of TB. So at minimum, as we saw for a drug-sensitive TB, we're going to be treating that person for 6 months, at least. For those who are drug-resistant TB, we're going to be treating up to 24 months. So there's a good indication for why we have a lot of people who fall off the bandwagon on being treated for TB. Already have gone over DOT and allows for ongoing clinical assessment so we can see just how far along they've progressed, if they have. And sometimes with DOT, which is nice, we might be able to simply treat them 1 to 3 times per week. So it doesn't mean that they have to go in every single day to get treatment. With the direct observational therapy, we can sometimes limit it to 1 to 3 times per week, which is great for convenience and keeping them active in their therapy. So the first line meds that we're going to be giving are isoniazid, rifampin, pyrazinamide, and ethambutol. These are normally all actually given together with drug-sensitive TB off the bat until at least the strain that individual has been identified and has had what medications it's sensitive to being identified. So isoniazid is generally considered superior to all the other alternative medications, and it's good for both active and latent TB. And a lot of people are running around with latent TB and they have no idea, and then suddenly they have maybe their immune system becomes more compromised, suddenly boom, they have active TB. So isoniazid can be either bactericidal or bacteriostatic. It's bactericidal during the dividing stage, and it's bacteriostatic during the resting stage. So for adverse effects, peripheral neuropathy is going to be our most common adverse effect, and it's dose dependent. So the higher the dose, the more peripheral neuropathy they're going to have. The patient can also develop hepatotoxicity, which can then lead to hepatitis. And the thought is that this is a result of the production of a toxic isoniazid metabolite that leads to the hepatotoxicity. Some patients can develop optic neuritis, and then some patients can develop anemia as well. Rifampin is going to be also a first-line anti-tubercular. This is a bactericidal medication and is broad spectrum. It's used for active latent TB, and this is important to remember, this is the one that is also good for leprosy. Some of the adverse effects, as is isoniazid, it is hepatotoxic and can lead to hepatitis. And all of these medications that are hepatotoxic can also sort of profound each other or act in a potentiating way to make the combined effect even more hepatotoxic. What's interesting also and is important to remember is that this is the one that can lead to discoloration of body fluids, including urine, sweat, saliva, tears. And we can also have GI disturbances, which are not uncommon, such as anorexia from just not feeling like I need to eat, nausea, and abdominal discomfort. Rifampin also has some drug interactions, such as inducing of P450 cytochrome, which can increase drug metabolism of specifically oral contraceptives, warfarin, and HIV drugs. So what that means for us is we're going to have to educate our patients who are taking rifampin to choose something other than a hormonal-based contraceptive. So maybe a copper IUD, or perhaps using both a cervical dam and a condom. I'm not sure actually if that's contraindicated. I'm not sure. That's one to look up. And then for warfarin, we're going to have to consider increasing our dose to ensure that they are not going to be at risk for developing a clot. And then isoniazid and pyrazinamide are going to be common to put together with rifampin and can all cause hepatotoxicity, which can potentiate the effect of hepatotoxicity by combining all those medications. Pyrazinamide is also a bactericidal first-line anti-tubercular for both active and latent TB. Again, hepatotoxic. Very rarely, some people can get hyperuricemia, and which can lead then to gout. Again, that's rare. What's not rare is GI disturbances, such as nausea, vomiting, diarrhea. And then what also isn't unrare is, what also is common is non-gout polyarthralgias, which is pain in multiple joints, and that can develop in 40% of patients. This can generally be managed by NSAIDs. Ethambutol, again, first line, is bacteriostatic, not bactericidal. This is used in the initial treatment of TB. So we may be dumping ethambutol after the first period rather than keeping going with it the entire time. It depends on what the policies are. Generally very well tolerated. We have a dose-related optic neuritis that can occur. So if we're giving high doses, there's more chance to develop optic neuritis. This can lead to blurred or constricted vision, perhaps poor color discrimination. Depending on how long we use this medication, how high the doses are, it may or may not resolve. So the big implications for us, we want to really, and we've done a really great job of this, promote screening. So we all have to be screened before we enter the program. We all have to be screened every year, sometimes twice a year, while in the program, and they take any positive screening very, very seriously. People who are incarcerated, people who are from other countries, especially developing nations. We're going to be screening these people as often as we can. And when we have a diagnosis, we're going to be checking the sputum culture, diagnosis being like a TB, skin test. I think it's TST, I don't remember what it's called. So a sputum culture is our definitive measure, but we're also going to do a chest x-ray to see if we have any pulmonary tubercles or pulmonary damage. We want to very, very quickly evaluate drug sensitivity so we know exactly which medications to put this person on. We want to report to the state, since this is mandatory, Um, this is something that we're going to have every single patient who has TB will be, I believe, within the first 1 to 2 days, working days of the discovery of TB. This will be reported to the state health department. And then we're going to promote adherence through direct observational therapy. All right, antiviral agents. So we have a limited ability to treat viral infections like, say, flu, HIV, because viruses use the host cells to reproduce. And so there's we have difficulty then in suppressing viral replication without doing significant harm to the host, which is us. So the general mechanism of action that we are able to use in combating viral infections is suppressing the biochemical processes that are unique to viral replication. So certain components that are needed for the virus to be able to replicate, we can find little kind of fun ways to tweak those and make it so they can't actually replicate. All right, so acyclovir is a prodrug. We covered what a prodrug was last term, but most people probably forgot. No offense if it was it last term? I can't even remember now. Regardless, and that wasn't meant to be offensive. A prodrug is one that is converted by something in the body to its active state. It kind of goes in a dormant state, something affects it like an enzyme, and that leads to it being finally activated. So in this case, with an antiviral therapy, perhaps in herpes virus, thymidine kinase, which is an enzyme, activates acyclovir to its active prodrug form, or active form. Why is this in a black background? Where's, no, oh, whatever. So uses, we have herpes virus family, so HSV. And the first line for herpes simplex, varicella zoster infections, basically shingles, chickenpox, herpes, and shingles and chickenpox can be treated with acyclovir if the dosing begins within 24 hours of the rash onset. And I believe there are, for shingles, other antiviral medications that we can use if it's past 24 hours. I don't remember. So viral resistance to acyclovir is very low, but it can occur from a decrease in viral thymidine kinase production. So if the virus tells itself to decrease how much kinase production or thymidine kinase production exists, that will limit how much of acyclovir can be converted from its prodrug state. It can also alter the conversion ability of the prodrug by altering thymidine kinase so that thymidine kinase doesn't actually convert acyclovir from its prodrug state in the first place. We can also have DNA resistance that occurs so that DNA polymerase is less sensitive to acyclovir's active state. There are some adverse effects that are route dependent. So if we give it via IV, there's a high chance of phlebitis, which means we want to change the IV site regularly. There's a chance for reversible nephrotoxicity, which means we're going to want to check our newly learned BUN creatinine levels. And rarely we can have some neurotoxicity. Actually, I don't think I found anything in the book about that, but so I don't know what that looks like. Maybe just some numbness and tingling. If we take it PO route, there's not really much of a common or significant effect. It's generally very well tolerated, but we may have nausea, vomiting, diarrhea, headaches, dizziness. When taken as a topical, there can be localized stinging as pretty much the only thing. So when it comes to acyclovir for interactions in teaching, when given IV, we want to use caution with dehydration since we have the potential for nephrotoxicity. We also want to be careful with giving it alongside any other nephrotoxic drugs due to the potential for nephrotoxicity. Acyclovir is also not a cure. It is only meant to try to reduce symptoms and to help kind of boost or give our immune system a chance to really attack the virus. We also want to teach about the techniques for decreasing HSV spread in the host, since if a person goes and scratches a wart, or not a wart, or would it be a wart, scratches a lesion from HSV in their groin and then goes up to their mouth, they can self-inoculate into their mouth. We also want to educate on safe sex practices to decrease HSV transmission. So when you have an outbreak, maybe don't have sex unless that person already also has HSV of the specific strain that you have. And at all times, use a condom or like a vaginal dam, for example. I don't remember exactly what the protocols are, but yeah. Influenza, serious respiratory tract infection, major cause of morbidity and mortality, tens of thousands of deaths per year. Virus goes under its constant evolution, which makes it really friggin' difficult to nail down a quality vaccination. Regardless, influenza is managed primarily by preemptive vaccination. I guess vaccination wouldn't always be preemptive. Vaccinations change yearly based on the identification of the circulating strains by these fancy organizations. Typically, they're based off of the northern or southern hemisphere, so whatever's going around in winter in the southern hemisphere, which is our summer in the northern hemisphere, they're going to use those as an indication to see what might affect the northern hemisphere as they come upon winter. Zanamivir is going to be our neuraminidase inhibitor, which is our mechanism of action, in that neuraminidase is required for viral replication. So we are literally just inhibiting neuraminidase. This is taken as an oral powder inhalation and is used for both influenza type A and type B. As with any dry powder oral inhalation, cough and sore throats are going to be common. In zanamivir specifically, we have severe bronchospasm, which is a potential, and will especially affect those who already have asthma and COPD or any other pre-existing lung disorder. There are no drug-to-drug interactions that are aware of, so we're safe from that perspective. When it comes to teaching, we want to tell our patients to go get checked out early to both potentially start the drugs and also to track the epidemiology of the flu. We want to teach them to start using the drug early to decrease the illness up to 3 days less than it would be otherwise. We can also potentially use it for prophylaxis after exposure and before symptoms. We also want to promote vaccination to try to prevent the flu in the first place and increase herd immunity. All right, so viral hepatitis. I don't know. Most common liver disorder. There are 6 different viruses that cause acute Am I saying that right? Hepatitis? I don't know. B, C, and D can also cause chronic hepatitis. I swear I'm not saying that right. Okay, whatever. So for hepatitis B, we have a vaccine, which I think we all are required to get, and are a series of 3 injections. I think it's like 1 month, 3 months, 6 months, or 1 month, 2 months, 6 months. And we can also have drugs to help treat it, such as interferon alphas and other antivirals. And this is a very vague slide, I think, because you guys are doing a project on hepatitis B. All right, HIV. So HIV promotes immunodeficiency by killing CD4 T lymphocytes, and we can use the more modern term called antiretroviral therapy, or ART, to significantly reduce the severity of HIV and the progression then to AIDS. I believe it used to be called highly active antiretroviral therapy, but both forms use like a 3-drug combinations to manage HIV. So the goals here of antiretroviral therapy is not to cure. We can't at this point cure HIV, but we can get to the point where it's not actually recognizable by modern technology. So we want to have early detection to delay the disease progression. We want to avoid drug resistance by using a polydrug therapy, because the more drugs you use, the less opportunity that those HIV viri are able to develop resistance. We also want to promote compliance by providing a convenient combination of drugs that they can take for the rest of their lives. We want to minimize clinical manifestations, prolong survival. We want to get a low baseline viremia, which is just the number of viruses in the blood, and then encourage high CD4 counts. So resistance is a major problem with HIV. Very rarely is it actually that we have a primary infection with drug-resistant HIV. Normally people don't just get it and suddenly it's drug-resistant. Usually it's the result of non-adherence. Same thing with TB. So people are going to have to be on medications for a very long time. Sometimes they may not be able to afford it or have access to a prescriber who's willing to give it to them. Number of barriers, very similar to TB, and that's usually how we end up getting drug-resistant HIV. So drug management evolution, we used to start with monotherapy, one medication to treat HIV. Now we've gone on to 3 or more medications through ART or HART, which will help to reduce drug resistance and promote better effects. And continuous therapy promotes or produces the best results. So there are 5 classifications of, come on, why do you keep going away? 5 classifications of antiretroviral therapies. So we have those that inhibit enzymes that are required for HIV survival and those that block HIV entry into the cells. So for those that block enzymes, we have reverse transcriptase inhibitors, which prevents the conversion of viral RNA into DNA. So, and those can be either nucleoside-based or non-nucleoside-based reverse transcriptase inhibitors. We can have integrase strand transfer inhibitors, which prevent viruses from integrating into the host DNA to then produce more viruses. We also have protease inhibitors, and protease is responsible for catalyzing the final step in the enzymes and proteins that HIV requires to reach maturation and begin replication. So inhibiting protease inhibits those actions. And then for blocking HIV into the gain entry into the cells, we have our fusion inhibitors, which will block viruses from being able to fuse to the outside of the cell. And if they can't fuse to the outside of the cell, they can't allow or inject their DNA into the cell. And then we have CCR5 antagonists, with CCR5s being receptors on the outside of our normal cells that some viruses are able to connect with and use as entry into the cell. CCR5 antagonists will block the virus from being able to bind to the CCR5 receptors on the outside of the cells, making that form of entry unavailable. And we have here a kind of nifty little chart showing how these work. So we have our protease inhibitors, which on this side it says interrupts formation of new virions, which is accurate. And then we have our CCR5 antagonists, which prevent HIV viron. Hang on. All right, I don't know where the heck I was because I had to help my cat chase this fly that he was going nuts after. Okay, so we have our fusion inhibitors, that block fusion between the virus and the target cell, so they block fusing cell here. The reverse transcriptase inhibitors stop the formation of DNA, so they block this ability. And then we have our integrase transfer inhibitors, which affect the ability for the DNA to then go, or RNA to then go and merge with the DNA in the cell. So that's basically how those work. Common side effects of HIV meds are all right here. The ones that I felt I made it kind of easier for myself to remember in that it redistributes fat from the face and arms to the abdomen, breasts, and traps. There is nephro and hepatotoxicity, nausea, vomiting, diarrhea, anemia, hyperglycemia and hyperlipidemia, neuropathy, rashes, and osteoporosis, osteopenia. So that's basically it for that. So there are two measurements that we're going to be using in the lab to try to determine how progressed the HIV has become or effective the treatment has been. So viral load will be the amount of viruses in the plasma via RNA. And this is the best measurement for predicting clinical outcome, as in how well the regimen is working. So if we see a lowering viremia, then we're going to have that indicate to us that this is working really well, and we might even be able to get down to non-observable levels of plasma HIV RNA. CD4 T cell counts will determine the advancement to AIDS. So if we're seeing the CD4 T cell counts going lower, that indicates after a certain point that they have reached AIDS. So if we have a patient with HIV who is pregnant, we're going to use the same general principles of therapy. There is mother-to-child transmission, and that transmission can be greatly reduced by using ART, which will then minimize maternal viral load, making it that much less likely that the newborn will acquire HIV from the get-go. Some of the special considerations, we can do pre-exposure prophylaxis, or PrEP, which will reduce the risk of contracting HIV, and we're going to use that or accomplish that with Truvada. Doing this can reduce infection risks by 44 to 73%. We can also do, so that's for people who are at very high risk of infection. We can also do post-exposure prophylaxis, or PEP, which can reduce the risk of infection after exposure. And we do that with 3 antiretroviral combinations, or a combo of those 3. So this should be initiated 1 to 2 hours after exposure and no later than 72 hours after exposure. It's then going to continue for 28 days. We're going to test for HIV serum or plasma levels at exposure, at 6 weeks, 12 weeks, and then at 6 months. And then for those who are born to HIV-positive mothers, we're going to start a multi-drug therapy at birth to try to prevent acquisition of HIV. All right, cancer therapy. So cancer is unregulated cell proliferation. We can treat that with surgery, radiation, drug therapy, and drug therapy is going to be our first line route for disseminated cancers, as in cancers that have metastasized or are by nature, such as with leukemia or lymphomas, spread throughout the body already. With cancer chemotherapy, we have to decide whether to treat or to not treat, based on whether the benefits of treatment outweigh the risks. If the risks outweigh the benefits, there's no benefit to giving chemotherapy. The patient must be informed of all the components to treatment and all the benefits versus risks. And one of these 3 should be possible in order to promote the choice for chemotherapy. Either the chance of a cure, chance of prolonging life, or chance of palliation, as in like pain relief or comfort for patients who have incurable cancer but are in so much pain from the cancer that this will make them more comfortable. Early detection is generally very rare with the exception of pap smears for cervical cancer. And the toxicity to healthy cells is dose limited or dose dependent. So the more we give, the more toxic we're going to have, toxic of an effect the healthy cells will experience. It's very difficult to make drugs since healthy cells and cancer cells are very, very similar. And cancer cells continue to mutate and can develop resistance to whatever we use to treat them. Cure also requires a 100% kill rate, and that can be very, very difficult. Because especially we have a minimum amount of help from the immune system because two reasons. One, the immune system doesn't recognize cancer, and two, the chemo will actually compromise the immune system, making it so that even if it did recognize the cancer in the first place, we're already dunting the immune system, so there's not much help with that it can offer. And solid tumors also have a poor response to chemotherapy because we have limited blood supply, location of it, such as in the brain, could make it very difficult to treat the cancer. And solid tumors also have lower growth fraction, which we'll get into over here, limiting the number of that are susceptible to chemo. So growth fraction is a very important idea in chemotherapy because it indicates what's susceptible to chemo and what's not, and which chemo agents are needing to be used. So a cell has four major phases: G1, S, G2, mitosis or M stage, and then there's also this sort of G0 stage. So G0 is a stage where a cell becomes mitotically dormant. They do not replicate and are not active participants in the cycle. Cells may remain in G0 for days, weeks, or even years, and G0 cells do not respond well in general to chemo. So the growth fraction is going to be the number of cells or the proportion of those that are in the dividing stage versus those that are in the G0 or resting stage. And this determines the tissue responsiveness to chemo. So if we have a high proportion of dividing cells, we have a high growth fraction, which means we have a high rate of response to chemo. If we have a low percentage or proportion of dividing cells, that means we're going to have a low growth fraction, such as in our solid tumors, and that's going to lead to a low response rate to chemotherapy. And chemotherapy drugs are also more toxic to any tissue in the body with a high growth fraction. So sperm cells, GI tract, hair follicles, bone marrow, which will then lead to anemia or in general pancytopenia. And these tissues will experience more damage from the chemo compared to those with low growth fractions. So drug classes, we got four here. We have our cytotoxic agents, which usually disrupt DNA synthesis processes. We have our hormones and hormone antagonists, which are generally going to be used for like breast and prostate cancer. We have our targeted drugs, which are specific to different types of cancers. And we have then our biologic response modifiers, which don't normally fight cancer itself. They help to allow our body to recover from the effects of chemo. For cytotoxic agents, these are going to be our largest class of anti-cancer drugs, and they act directly on cancer cells and on healthy cells to cause their death. Only around 50% of them are phase-specific regarding whether they affect G0, G1, G2, S, M, and they are subdivided into 9 major categories, which thank God we don't have to learn, for whether they are cell cycle phase specific or not. The specific drugs, as in those that affect whether G1, G0, M, or S, they are toxic only to cells that are in that specific phase. and they attack generally high growth factor or fraction tumors. They must also be in the blood continuously over a long time period. Non-specific drugs, on the other hand, are toxic during any phase of cell cycle, and they do attack both low and high growth fraction tumors. I believe in general, though, they still affect high growth fraction tumors more often and more strongly, than low growth fraction tumors. They're also dose dependent, so the more dose you give, the better they respond. Common adverse effects for cytotoxic agents: bone marrow suppression leading to, in general, pancytopenia, digestive tract injury, so nausea, vomiting, diarrhea. We can have mucositis, which is inflammation of the whole GI tract, stomatitis, which will be then mouth inflammation, and alopecia, which is one of the most distressing psychologically effects of chemotherapy. Though there are potential ways to eliminate or at least reduce dramatically alopecia, but we're talking about some very significant some very significant inconveniences to try to avoid hair loss. Other adverse effects are going to include hyperuricemia, which can lead then to gout, reproductive toxicity or infertility, because our reproductive cells are very high growth fraction cells, so that leads to a much higher response to chemotherapy. Local injury from extravasation, which we can see down here, that's bad juju. And all chemotherapy drugs are carcinogenic, especially our cytotoxic agents, and any cancer or any chemotherapy, anything that kills cancer can also cause cancer. So hormonal agents are primarily for breast and prostate cancer, and they mimic or block the actions of endogenous hormones. That's pretty straightforward. Targeted agents hope to be more selective to what they affect and are designed to bind with specific molecules. Many are actually antibodies that bind with specific antigens that are found only on tumor cells that will then signal the immune system to respond. So it's sort of a way around the idea that the immune system doesn't actually respond directly to these cells, helps to kind of trick it into responding after all anyway. Immunostimulants or biologic response modifiers, they enhance the host's immune attack against the cells or against cancer cells. Or, let's see, what is a little picture there? Tumor antigen as a marker to help tell the body, hey, attack this cancer cell. We also have biologic response modifiers that help to promote recovery from the dangerous chemo agents that we use. So epoetin alpha or epogen will stimulate erythrocyte synthesis, which will be used then to produce more red blood cells in the case of severe anemia. We also have filgrastim or Neupogen, which is a human granulocyte colony stimulating factor used to produce more white blood cells when we have severe neutropenia. And glucocorticoids are our last medication for chemo. They are used in addition to other agents to treat specifically lymphoid cancers, since lymphoid cancers tend to be very responsive and lymphoid tissue responsive to glucocorticoids. Very high doses are required in order to create this anti-cancer effect. Unfortunately, we have multiple very serious side effects, as with any time we give glucocorticoids in very high pharmacologic doses, such as osteoporosis, adrenal insufficiency, infection, GI ulcers, fluid and electrolyte imbalances, diabetes. But we also have some other non-directly cancer-related effects that we can give just to make the cancer treatment better, in that we can suppress the chemotherapy-induced nausea and vomiting, and we can also reduce the cerebral edema when we have brain metastases and brain irradiation. We can also reduce pain and inflammation associated with cancer in general, and we can improve appetite and promote weight gain. through taking chemo or glucocorticoids.